We're live.
Good evening. We have with us today Dr. Fobi Adusa-Amankwa, who is an alumnus of PRESEC and also University of Ghana Medical School. Fobi, would you like to introduce yourself to us and tell us a bit about yourself?
Thank you very much, Barbara. And thanks for having me. And it's a pleasure to talk about something I'm very passionate about. Yes, after sixth form in our day, we used to do national service. So I ended up doing national service with my dad. He had a clinic, conduct clinic, and for a year of national service, I spent time there doing most things from procurement to dealing with patients in reception, taking vital signs and all that, registration cards and all that. Anyway, I saw the difference that health personnel could make in people's lives. And I decided that, yes, medical school was probably the place for me. Fortunately, I got the grades and ended up in the University of Ghana Medical School in the next 6 years, where I met equally fascinating people, lecturers, brilliant lecturers, passionate lecturers, people who had very good bedside manner, others who didn't. And it appreciate all the important things about patient care. After medical school and house job, I wanted to do radiology. So I ended up sitting in the radiology department for about 2 years, after which I left for the UK and somehow ended up getting into adult and elderly medicine. There I have been for the last 20 years, and I've just come back home, determined to set up a private practice, patient service to start with, and to alongside run home care service, especially for adults. I hope my pediatric colleagues will join hands with me at some point and do the same young. In a nutshell, that's me.
Thank you very much. I must say that those of us of a certain age, which quite a few of us on the forum are now becoming very concerned with home care because you realize that we can't always have access to hospitals and things like that, and home care is very important. Previously, this had been left to relatives and things to handle, but it will be extremely important to have specialist care in the home. Our first question for you is, what is palliative care? You've explained to us somehow what made you interested in it, but if you can still go over that again. So what is palliative care?
And there's WHO definition for palliative care, which although I do not entirely agree with, I think that it's probably one of the best definitions out there. So it's defined as an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment. Now, the thing is, talk about life-threatening illnesses. When you talk to a doctor or health personnel about life-threatening illnesses, the first thing that comes to mind is acute things like pulmonary embolism, heart attack, diabetic emergencies, and all that. But in palliative care, we're dealing with chronic conditions that have an effect on lowering your lifespan, shortening your lifespan. So I think that the more appropriate description would be life-limiting illness rather than life-limiting illnesses. Anyway, that's just by the way of definition. Now, it encompasses looking at holistic approach, psychosocial, spiritual problems, physical problems like pain, vomiting, and all that are associated with treatment of symptoms of these chronic illnesses. So you can see that it requires a multidisciplinary approach. I mean, you have pastors and religious leaders involved, depending on your faith. You have therapists, occupational therapists, you've got doctors, nurses, specialist nurses, you've got even volunteers who, just by holding a hand and listening to what the patient going through this agonizing time says, a difference. And so, in a nutshell, that's what palliative care is.
So, what is meant by quality medical care at home in Ghana?
I mean, there already are a significant number of nursing agencies that have grown over the years. I mean, 20 years ago when we were in medical school, I don't think we had more than a couple of nursing agencies who were delivering home care. Now, Ghana Business Directory alone lists about 19. I'm sure if you go to the register, the statutory bodies that register the health institutions, will find much more than that. Home health care has already been delivered. No problem about that. The issue is about improving the quality, and it's crucial because if we expect to deliver the standard of home care that we see, or the standard of care that we see in hospitals, then it should be clear to us that we need to be good at things like record keeping. We need to be good at handing over from shift to shift. We need to be good at reading reviews of other health personnel who have come. And importantly, we need to have an escalation plan. If things go wrong with the patient, we are looking after at home. So doing all this is part of improving the quality. It has been delivered already. All we're doing is to make sure that it is delivered in very safe, almost risk-free environment and manner to the patient.
So the next question is, can it be qualitatively and quantitatively determined?
Of course. I mean, qualitatively, you can look at things like surveys. You can do design questionnaire, ask patients or clients, as they are sometimes called, relatives. You can also ask staff who are delivering the care questions related to whether they are satisfied with what is being done and all that. And that gives you a good feedback on areas of weakness, which there would be, and because we're only human, and areas to improve. So yes, qualitatively that can happen. Quantitatively, you can do audits. You can get either within the organization or outside the organization to come and audit things like record keeping, several times between escalating a problem and the response by the decision maker. So, for instance, if a patient we're looking after in the home is unwell, with complaints of feeling unwell, if nursing assistant or a doctor, a designated doctor, to come and see the patient or for advice, how long does it take for decisions to be made? These are easy to measure, determine whether they are safe or not. Again, when you've got patients who become unwell and end up in hospital, you could always look back, see whether the report, there were triggers that caused that deterioration in condition, and whether it could have been detected earlier to prevent the person getting worse than they were. So it can be measured quantitatively.
Another question is, who are the target patients and carers?
For my service that I intend setting up, that I'm setting up, because I have been in adult and elderly medicine, my target patient group will be those above 18 who have significant mobility problems or problems with cognition, which is basically thought processes that prevents them, memory issues that prevent them from seeking treatment and outpatient service. The reason being that I encourage patients to exercise. So if my patient is well enough to sit in the car easily or take public transport and go to the hospital or clinic review, I'd encourage that. And loads of patients who don't have that ability, in young adults and children who have conditions like autism and all that, who struggle when they go out to crowds. So it is important that my pediatric colleagues will join, hopefully, in this initiative and come on board because they have the expertise, the knowledge and know-how to look after children, which I must admit I'm not very good at.
Do you have any metrics for the current level of medical home care in Ghana or anywhere else in Africa today?
Unfortunately, there's a dearth of research that. Um, so no, I don't. I mean, I know that in Southern and Eastern Africa, due to the AIDS epidemic, a lot of home care was delivered. I mean, that's a different set of patients who there's a lot we can learn from those services, but we cannot extrapolate the experiences and all that and measurements taking to our patient group. So no, but there's hope. In 2016, the University of Ghana set up a center for gene studies, the CFAS, and there are a lot of researchers there who are ready look at services like what we're setting up and that research give us evidence base that we need to move this initiative forward.
So how is this going to be funded?
At the moment, it's going to be privately funded. That's the plan. I mean, people are already paying for home care services. The problem I found speaking to a lot of owners and managers of these home care nursing services is that they don't have, most of them do not have a dedicated doctor for patients to look after. So when there's a problem, either send the patient to hospital or, I mean, a hospital that the patient has been to before, depending on the family's choice or the patient's choice, or the nearest hospital. Medical staff there, nursing staff there may not have information on the patient. And medicine is important. I mean, new research, what we've known all along, that continuity of care by the same teams improves patient outcomes in terms of good health. So that is where we intend plugging in by supporting home care nursing services that are already in existence and doing a good job.
Okay, so I anticipate that this might be quite expensive for the families involved. For example, if you have an elderly mother who has a terminal disease and needs a lot of care at home, it could be quite expensive.
Yes.
So is there any support that I know it's going to be privately funded, but are you going to give any support to some of these families in terms of where to look for insurance and things like that? Advise them where to go for extra help, be
Yes,
able to to finance it.
yes, it's unfortunate. The insurance companies, the private health insurance companies are doing a very good job. They believe it or not, before the private health insurance came in, many private clinics folded up because patients did not have money to pay for the bills. But private health insurance has covered a lot of that. Unfortunately, they and the National Health Insurance Scheme don't cover chronic illness. Neither do they cover elderly, about 60. So most of their policies are targeted at the young. And it's because the older you go, the more likely you are to fall ill. And so it's not a good business practice to do that. I mean, the state has had a few initiatives. I mean, to put money in the pockets of those who are living below the poverty line. Unfortunately, um, my experience in the basic nursing services, you need to have money to pay for that. I know that certain NGOs have tried to help. There's Health Concern Ghana who have been advocates for that. There's Health Age Ghana. There's the Association of Ghanaian Elderly Age. But unfortunately, it's not enough. I am hoping that if we're able to prove that this service we are setting up is cost effective, government will commit some funds or probably add it to the national health insurance scheme.
So I suppose you'd then have to educate the younger folk to try and take out insurance to cover this in the future, as these things are done in the UK.
Exactly. I think that it's important that the younger you are, once you start working, you get some illness. You can add a life insurance policy. Although the money doesn't come to you because with life insurance policy, it's paid out when you die. But it's
Critical illness.
yes, critical illness policies. In that if you fall ill, and it's covered, whatever your diagnosis is covered, then you don't need to worry about funding it. You can get the best care available for to make sure you get better.
Thanks for your answers. Sorry to jump in. Just a quick question in regards to the insurance. Are there any available insurance which one can take as a Ghanaian that would help in case you have any illnesses or you have parents that have any serious illnesses that they can hopefully enjoy the benefits of locality care that you currently provided?
Fortunately, no. None of the private health insurance companies look at the elderly or those with chronic illnesses exclusively. What I'm hoping to do is to convince them to probably incorporate it into a family policy. So if you take out a policy for you, your wife, children, it's a family policy. Hopefully they would agree that you can add mom, dad, your aunt who's over 60 to your policy, and hopefully that will balance the figures a bit. But regards to exclusive policies for chronic illness, and there are none at the moment on the market, as far as I'm aware.
Is there a big difference between the kind of insurance we're discussing today and the NHIS insurance?
Well, I think the big difference is that NHIS insurance is quite cheap. So, yes, there is. The NHIS insurance, as I am reliably informed, does not cover illnesses that whose treatment duration is not defined from the onset. That is the problem. Most illnesses, you cannot put a figure to it. If you've got heart failure, live for 10 years, then you've got heart failure and live for 10 years. At the onset, nobody knows whether you live for 10 years or you live for 20 years. So, in that regard, my understanding is that under the NHIS, that neither the private insurance, health insurance companies also cover that with any of the policies. So, the situation of private funding by family members, funding by patients themselves. I'm hoping that will change. We are supposed to be a middle income country now, and hopefully, if the economy improves, things will improve as well. There's private health insurance. I said 25 years ago, the economy was not good. We didn't have that at all. So we've come a long way, but there's still a lot more to do.
Excellent.
I suppose, sorry, go on, Theo.
Yeah, so now we know that the main or what would actually help most Ghanaian families is that either the insurance companies or the government in collaboration with the insurance companies find a solution in terms of an insurance policy that would help most families. Is that what you're saying?
Yes. And there's a national agent policy. That is a very good idea. It was first written in 2003, was revised in 2010. I haven't seen the first two drafts. Currently, last year, it was being revised by the new government. It's yet laid before Parliament. I mean, the first draft was in 2003. We're in 2019, 16 years on. It is yet to be laid before Parliament. I'm hoping that I'll grab a copy quickly once it's been revised and read through it. And in there, we might have suggestions for funding. As of now, without it being law, we are stuck with what we have, which is grossly inadequate.
Okay.
Are there any care homes for the elderly and disabled in Ghana?
Yes, I mean, my search, I look at the internet and all that, but there might be some that haven't come up, are not available on the internet. But yes, as far as I know, there's one called the Mercy Care Home, Sakono, that is privately run. I happen to have a friend who lives in the UK, whose mum was there, the only surviving child of his mum. She was there for 5 years. She died in the mid-90s, late last year. And he has been happy, or he had been happy throughout about the care. I know also that she had to go to hospital for surgery about a few months before she died, which meant that there was an explanation plan of some sort. And she felt ill, she was sent to hospital. So I think, yes, I haven't been there, I haven't looked at something, but what I've heard so far from him, it seems to be a good one. In terms of care homes for dementia, because, you know, in England, if you have a care home, you must be specifically registered to take in people with dementia. And if you don't have that special registration, then you're not able to take them. because dementia care requires certain special skills. But as far as I know, the care home that we have hasn't got that discrimination. I don't think we've got the law even discriminates anyway between patients with memory problems. And if you want to go to a care home, there's that one care home that you have to apply to go to. Interestingly, last year, a gentleman who came to see me, who had plans of setting up a care home, but when he looked at the cost and of running it and the fees that would have to be charged, he didn't think that it was financially viable. So that is the problem. I mean, competing, if you've got a building, you're competing with whether you should use it as a guest house. Today there's Airbnb, or whether to use it as a care home. And so far, I don't think the funding, privately funded, meets the need or meets the running costs of the home. England, again, social services funds most of the care. If you've got money, savings up to something in the region of about 23,000 or above, and if you need to go into a home, your money is used. When you get to that tough threshold, then it's so yes, cost of care in England in institutional care differs from area to area because the property prices differ and all that. But it is largely funded, if you don't have the money, by the state. And so we probably need something like that here that will help.
What about hospices? I know that there are hospices in England that deal with people who are nearing the end of their lives due to terminal illnesses.
I mean, hospices are specialized units that look after people with chronic illnesses, usually for two reasons. If they have symptoms that are difficult to control, example, pain that hasn't responded to first line treatment, vomiting that is persistent, then you could get them into a hospice where there's specialized care and they're admitted as inpatients and those problems solved. Other criteria for admission to hospices is to it's end of life care. If it is determined that you are within 2 weeks of dying, then hospices will take you in. And this is because hospices have limited beds. And they also are shifting towards being palliative care within the home setting or within the institute, which includes institutions, residential homes and nursing homes. But, about 10 years ago, I got an email from a gentleman who was setting up a hospice in the Ashanti region, somewhere near Kumasi. I don't know what has come of it. I've looked for it on the internet. I haven't found it there. But I hope to check up with statutory body that regulates these health institutions and registers them. Hopefully, something might come up. There's a hospice that is being built north, somewhere towards Florida. It's headed by Bobby Benson that I read about. I know they have not completed it yet. We're hoping that when it's completed, there'll be some hospice care. I also know about the West African Foundation. Started hospice care initially. I'm not sure whether when they started with inpatient hospice care, but certainly what I've read, they don't offer inpatient hospice care at the moment. So the question to your answer is no. As far as I know, there is no hospice care available in institutions, but most of it is delivered at home in general hospitals. That is a problem because people may not have the requisite skills to deal with all the problems.
So if you wanted home care for a relative, how would you access that information? Is there a list of doctors and laboratories and emergency services that can be used, or you can tap into to help support you?
Most of the major laboratories run home service. So the big laboratories, if you phone them, they can come home and take blood samples that doctors have requested and all that at home. In terms of doctors, it's a hit and miss situation. I know that most or a lot of doctors would rather see patients in a setting and see them at home. Traditionally, that's what done. However, there are a few who usually would go home, see patients they have been in with them or they have known in the past, and who now cannot physically come to the setting. And there are a few who also see new patients and go to the homes, but they're few and far between. From my discussions with the health nursing care providers, I don't think that there are many doctors who are dedicated to covering service. And that's what I hope we will change this initiative.
Right. So that what you're saying is that because we don't have formal home care, much formal home care, we could train the relatives and helpers so that they can step in and do that work until we have a more effective means of doing it.
Oh yes, I think that a lot of patients, especially those with memory problems, feel comfortable being looked after by their relatives and not strangers all over the world. I'm fortunate here that culturally we see it as a duty to look after the elderly members of our family. And so it is important that we tap into that and train willing family members to do that. From a business point of view, will nursing care services happy to train family members when it takes away business? Some would, some won't. But I'm hoping that we will be able to organize a training manual, use visual material and all that, to organize formal sessions for training for carers that are interested and go on with it. I mean, many patients use boxed boxes, pill boxes, or where they labeled Monday, Tuesday to Sunday, and morning, afternoon, evening, night. These boxes are filled with the medication for the patient by their relatives. So, yes, relatives play a very important role, and we should use them as much as we can, especially since the funding is not there at the moment for professional healthcare.
So I believe some of the causes of the major illnesses could be heart attacks, high blood pressure, pneumonia, diabetes. And these are some of the illnesses that result in the need for home care. To what extent can these be avoided?
I think prevention is crucial in avoiding chronic illnesses, also the acute ones. It's very crucial, but that's a huge topic that requires a whole session to deal with. Lifestyle changes, exercising, eating healthily, avoiding excessive alcohol intake, avoiding smoking, which is known to cause lung cancers, so avoiding obesity. So yes, to a large extent, we can prevent some of these chronic illnesses. But into that session will probably us from factors from what we intend talking about or what we're talking about. But that's a whole other session, and I think I'm happy to do another session on that in the future.
We mentioned in relation to training family members to help support their families. I mean, how would you do that effectively? Because we realize that a lot of family members, it's all very voluntary. Some of them are not educated.
Yes.
And some of them even do it reluctantly.
Yes. I mean, that's why I use the word willing. I think nobody should be forced into looking after a relative who is indisposed, because you run the risk of abuse. Sometimes is intentional and sometimes is unintentional. And abuse is a big problem now. People, both professional carers and family members, have been prosecuted in England, America, abusing vulnerable relatives, or patients under their care. So I think that when we identify someone who needs help and the family can afford professional services, we go with it. Even where they can afford professional services, I think it's important that family members are educated about the condition, educated about the cost that the condition or the illness will take, and so that surprises are not sprung on them. And also, they serve as the checks because they love their relative. They serve as a check for professional carers who are performing under par. If they know what is expected, then they know to escalate issues. Okay. So, even if a carer, a family member that is not willing to be a carer, they can still be educated on the condition so that they serve as a check to alert care providers, managers, and staff, senior staff, as to poor care that may be going on.
So is the delivery of quality medical care at home a national initiative? If so, how is it being run? And if not?
Fortunately, for the reasons I've enumerated, including funding, it's not a national initiative. I'm hoping that we'll bring on the researchers. When we start, we would work hand in hand. I mean, there's departments of sociology in a few universities who are interested in this. There are nursing departments in the universities who are also interested in this. There's a Center for Aging Studies that I mentioned. There are public health institutions, two of them, one in the States, a state-run one in Legon, and another one called Ensign in Adusa. They all have students and lecturers who I'm sure will be happy to conduct research. That research will give us the body of evidence that we need to convince government that it is worth putting money in home-based care. I mean, at the end of the day, every patient that you successfully manage to look well after at home without having the need to go to hospital saves a bed for somebody who needs acute hospital care in a bed. We know about the bed crisis that has happened in the last probably 20, 30 years. The worst one we heard about last year was when a 70-year-old gentleman not be reviewed in 6 hospitals because there was no bed, and eventually died in the 7th before he could be seen. So these delays happen in hospitals where you might find patients who can be looked after at home, but because there are no good services supported by doctors, supported by physiotherapists, supported by other health personnel to deliver that care, the patients are kept in hospital beds, which is not the best for them anyway, because they catch infections, chest infections, urine infections in hospitals, because hospitals are the worst breeding grounds for bacteria.
I have an answer here that says that it's not a national initiative, but it will start on a small scale in conjunction with the setting up of an outpatient clinic service as a pilot.
Yes.
So what exactly will an outpatient clinic be doing in terms of assisting with the home care service?
Yeah. So my plan is that I'm setting up an outpatient clinic service, because that is what all doctors traditionally do. Most of your patients come to you in the clinic setting. Yes, it saves time that you would use to spend to get to visit people at home. So you can see 10 patients in a clinic setting, and within the same period of time, you might only see 3 or 4 or 5 patients at home because of the travel times. So yes, we're setting up an outpatient clinic service. What it will also do is that with that service, you can rotate staff through the home care duties and outpatient clinic duties, which then gives them a variety of skills. You see, when you confine somebody just to home care, they may lose certain skills that you get in an outpatient clinic as well. So the plan is to tie the two in and rotate staff, which help in their training and make them more versatile in dealing with patient population.
So I see that this will also include dental practitioners, so not simply physical illnesses, but also and mental illnesses, but also dental practitioners.
Yes.
So
yes, dental health is important. I mean, a lot of patients with memory problems struggle with physical problems, arthritis and all, struggle to maintain good dental hygiene. So dentists are important, pharmacists are important, therapists are important in this initiative, and we are hoping that we can pull them on board. The thing is that we have to reorient ourselves as health personnel, because we are used to practicing within hospital settings. But that change must happen now. We need to change and move towards rendering some of these services within the home environment, so that patients who cannot get to institutions are not neglected.
Is there any plan to involve governmental health authorities, local clinics, NGOs, philanthropists, local media, etc.?
They all have an important role to play. So as we gather the evidence, because what we are doing here is we are trying to use this to convert many people to believe in it. There are many doctors, nurses who will argue that home is not a place to treat sick patients. With my experience working in England, working here, I mean, I've treated so many patients at home who didn't need to go into hospital. I don't think that is misplaced, and I think we need to provide the evidence that will convince many to come on board. There's a society of general medical and dental practitioners, and these are all private practitioners. I am hoping that if, for instance, we get a referral from Dansoman, I mean, there will be a practitioner, a doctor in Dansoman, who will be prepared to take the patient on, rather than a doctor sitting in East Legon or somewhere, who has to drive halfway across town to look after a patient there. I mean, it will be difficult to respond to emergencies, and you spend a lot of time in traffic when you could be treating other patients. So hopefully with time, it will end up being local initiatives. But if we are able to get government on board, and we need the evidence to do that, all well and good. But I'm sure it will happen. It will take time to convincing, but we are persistent, and it will happen.
Okay. Because what I've noticed about Ghana is that you have local GPs. For example, you have a number of GP servicing East Cantonments or East Legon or places like that.
Yes.
So then you'll try and engage them to do the home service locally as well.
Yes. We
Is
will
that the plan?
do presentations once the service is up and running. When it's not up and running, it's difficult to convince people that it will work. So when it's up and running, we'll do presentations at nursing associations, we'll do presentations in nursing schools, we'll do presentations in medical schools, we'll do presentations to practitioners already there, and try and get people to think about it. At the moment, we know that there is a huge delay in recruiting medical and nursing graduates because there's simply no funds. So we know a lot of them would end up in the private sector, and a lot of them would end up working in home care services. So we need now to even take those skills and teach them in the schools before people graduate, because for the first time in our history, we have unemployed doctors, unemployed nurses, and I'm sure unemployed therapists. And so we welcome them to private sector and hope that if the private sector grows in terms of home services, we can absorb as many of them as possible to run the service. In places where these services exist, they've worked out to be cheaper than hospital care.
So, by the looks of things, from the discussions that we've just held, it looks like this is quite a new initiative, as enormous and as important as it is. Is that correct, though?
Well, I'm sure there are certain doctors who are already plugging into services, but I don't think that there's any research going on in that area. I think every doctor must be involved in all three things. The first is delivering care directly to patients, so medical treatment to patients directly, which is the core business. The second one is teaching and imparting knowledge, because the more experienced you become, the more practical knowledge and you can give to mentees. So teaching either bedside, it doesn't have to be formal teaching in a classroom, teaching at the bedside, teaching in a consulting room. It's important that people impart knowledge. The third thing is partaking in research. I mean, you don't have to be the lead researcher. I will struggle to be a lead researcher. I don't have the time, I don't have the patience and all. But I think that convincing your patients to be available and the data to be used for research, convincing them to be part of research, collaborating with primary researchers and all that is crucial, because that will give us the body of evidence to know where to put the scanty resources and how to do it and what works and what doesn't work.
This initiative, we are aware that it's going to help a lot of people, but then won't it detract from the profitability of private clinics and things like in institutions like that? What's your opinion about it? I mean, how are the private clinics going to assist you if it's going to take away money from their pockets?
Yeah, I think with there are two types of private clinics or hospitals. I mean, there are those that have admission facilities and those that don't. For those that don't run admission facilities, it probably is not too difficult to convince them that, look, running a home care service or plugging into an existing home care nursing service already and supporting them will still earn you some money, will still earn your organization some money. So that's not too difficult. The difficulty is in convincing organizations that have invested in beds that rather than bring the patient to the hospital, that patient can be looked after at home. From experience, most of the patients in private hospitals who get worse end up in the big government hospitals. I mean, from experience, it happens. if a home care service is good, it will hopefully identify patients who are getting ill early. Most patients would rather, and relatives would rather, be looked after in their local area. So the private hospital will be the place of choice for these patients who are identified and cannot be looked after at home. No home care service can prevent hospital admissions 100%. They will be sent to these hospitals anyway. The important thing is that because they get there early, they probably would not have to move on to the big hospitals and spend their entire admission period in that hospital. So rather than taking on patients and halfway through having to send them, the deterioration is detected early, brought in early, and they can be stabilized and kept there for the entire life. So, in fact, if it's run properly, most patients who will be rushed to the big hospitals in the first place because they are very unwell would rather come to local services. So it remains to be seen whether that will happen. A good home care service will result in patients' conditions being, when they worsen, being detected and then being amenable to local treatment in hospitals rather than going all the way to big hospitals. And the patients and their relatives want that anyway.
Given that some people already give medical home care in Ghana, how can the quality of such care be improved?
I've talked about some of them. One of them is good record keeping, good handing over. That is the bane. Even in big hospitals, that is a problem. Handing over is not rigid, and so certain decisions that have been taken that are not documented properly do not pass on, and relatives get frustrated or patients get frustrated when they have been promised that something is going to be done and the thing is not done after 48 hours. So good record keeping is key to improving the service. Again, auditing the things you do. If it's about wound care, you've got to audit it. Things like recording um, uh, episodes or events of pressure ulcers. Pressure ulcers universally now are accepted as being a result of poor nursing care. So if you have 10 patients who are bedridden you're looking after, and 5 of them develop pressure ulcers, whilst there's another care provider who has a similar number of patients who are bedridden, and yet a smaller number get pressure ulcers, it is clear that one is not performing well, and remedial measures can be put in place. So these are things: auditing your practice, auditing, looking at the patients who, for instance, get unwell under your care and have to be rushed to hospital as an emergency, looking at what happened, looking at whether it could have been detected, reviewing the care you gave is important. These are the things that improve quality. It's not just about having the knowledge. It's about auditing and re-auditing and comparing your service with what others are doing.
So presumably these will be regulated because, for example, the care homes you have in England, they are regulated. So are these going to be regulated then by external?
Well, so far the regulation hasn't been good. I mean, it is not rigid. Care services are registered and it's a prerequisite, but who supervises them? Who deals with the complaints processes, if there are any? All that is important because that is what leads to regulation. If to improvement in care and maintaining good standards. So if there are regulators, the Nursing and Midwife Council is there as regulator of nurses and midwives. The Ghana Medical and Dental Council is there. There's an allied health council that I read about that is yet to have a governing board, but I read about them a couple of days ago, incidentally, and they are all there. But for them to be effective, there must be very good training first for the personnel delivering the care, and there must be um, um, a process of looking at complaints, not in a bad way, not just to penalize personnel, but to institute measures, see where the weaknesses are, and institute measures to remedy the situation. So I think that is important. Regulation has always been a problem, and I guess with the advent of home care services, even regulation within the home care environment would even be more difficult, which is why training, auditing, good record keeping, and all those standards of care, implementing them and ensuring that they are kept and done well is crucial.
So, in a nutshell, what do you see as your role? What do you want to happen? What are you going to do? What do you get
What
me?
am I going to do?
What is your role? What are you going to do?
Okay. Well, my role is a crusader. I'm a crusader for home care services, especially for the elderly. I'm hoping my pediatric colleagues will join and do the same for children. I'm hoping my colleagues in brain health will also join and do the same for the patients with dementia, providing specialist care and all that. At the moment, our cancer specialists are advocating for more care at home worldwide and in Ghana. They tell me that they are always um, struggling and arguing with colleagues in emergency room not to admit their patients, because once somebody has cancer and somebody has come in and is ill and has cancer, the default position is to admit them. So it's a crusade, but it's a crusade that we need to have evidence for, to convince people to change their way of practice. And that's what I see myself as being, a crusader.
Right. So not in providing the services yourself, but in trying to facilitate it.
Yes.
Right. Theo, do you have any questions about what has been discussed so far?
In a nutshell, I've realized that there's quite a lot that we are behind on in terms of.
I can hear you well.
Okay, can you hear me now?
Yeah, that's fine.
Can you hear me now?
Yeah.
Okay, so in a nutshell, it seems that we are quite behind in our elderly care and also in maintaining and trying to merge in terms of with the hospitals and healthcare facilities and doctors available, which is something that is quite important, especially to those of us in our current year groups. You know,
oh, sorry, I missed that. I think it's, let me just.
Okay. In the meantime, whilst we're waiting, sorry.
Yeah, I can hear you better.
Sorry, guys. Those of you watching, apologies for any technical issues. We do have these often now and again, but hopefully we'll try our best to make sure that you have very good viewing and listening opportunities. Doc, can you tell us a bit more about the current situation in Ghana in terms of elderly care and child care and palliative care, please?
Okay. So the current situation in Ghana is that we've got two hospitals in Accra, for instance. I don't know too much about Kumasi and the other regions. In Accra, we've got two hospitals that deliver cancer care. One of them is Kolebu. There's a national radiotherapy unit there. They are good specialists and all that. Don't have admission facilities. If you need to be admitted, you have to go to the general ward, admitted, and then specialists will come and see you, help in the management of your condition. There's a private Ghana Swedish Medical Center that also specialized in cancer care, but they also provide an outpatient service. So it is important that we identify institutions that can take on patients who have diagnosis of cancer when they have complications, and that they get the right care there from skilled health personnel. So that is one area. We don't have hospices, but generally, the world is moving away from hospice care. There still is the need for hospice care for patients who are very, very unwell, cannot be managed at home. We're moving towards providing palliative care in the home, and that's the situation in Ghana as well. In terms of elderly medicine, yes, there's a Center for Human Aging Studies, so that's a very good one. There is a dementia clinic that is held once a week in Kolebu. So you have people interested in dementia and memory problems, reviewing patients and making diagnoses and all that, which is crucial. There is, as part of the family medicine course, graduate course that is run by the Ghana Graduate College of Physicians and Surgeons. Pediatric medicine is now a fellowship. Family medicine is now a fellowship under that. So people who to do family medicine can go on to get a fellowship in medicine, which is a good thing. Pediatric medicine has been incorporated into the curriculum of the University of Cape Coast Medical School and the University of Ghana Medical School. I don't know too much about the NUSD Medical School. This wasn't so in our day. So things are changing. I mean, problems in children like autism, which wasn't taught in our day in medical school, are now being taught. NGOs creating awareness and all that. So I think that the situation is better than it was in terms of the training of health personnel and the curriculums in school to reflect the changing trends and acceptance that the population is increasing. The age of the population is increasing. I think that there are some statistics that I have, and the 2010 population census shows that the over 65s are increasing. And by 2050, I think there's estimated that there will be about 0.5 million people over the age of 80, if I remember. So the problem is not going to go away. We need to develop innovative solutions to deal with the problem. Thankfully, even though we talk about the breakdown of the extended family, people still have a sense of responsibility towards non-nuclear family members, and that's a good thing that we need to keep going and work on that. But the NGOs that I know of, Help Age Ghana, Health Concern Ghana, the Association of Ghanaian Elders Age, there is the Art Lifestyle Lounge, which is in Jolo, which runs a day center for the elderly, and they come, they have activities and all that. There's a dance class, which is good for exercise. That is one of the Institute of African Studies in conjunction with the Center for Aging Studies. So things are happening, and hopefully, if this national aging policy is well written and becomes law, like I said, I'll have a look at it when the revised document comes out. and becomes law, we will be in a better position to deliver services to the vulnerable in our society.
Excellent. Thank you so much, Doc. No, so basically, we're going to go back to our questions from our viewers and also from the members. So the next question that we're going to ask is, this initiative may help the people that most need it. However, wouldn't it distract from profitability of private clinics and such like and the kinds of other clinics in Ghana? What is your take on it?
I think it will help the private clinics. I think that it's good to also know how your patients live at home. You're not going to spy on them and see what they're doing and what biases they have, but it's good to know how they live at home, because a patient comes to you in clinic. It's a different environment. It's your environment. May not feel confident to talk about all the problems they have in their own home where they are boss. They might talk about the things that they wouldn't have spoken about. So it gives you an insight to understanding your patient. And I think that doctors will come around to it. In terms of cost, it might be that because the time spent traveling to see a patient at home has to be factored in. I think that it'll be a bit more expensive than doing a consultation in a clinic setting. But I'm sure that a lot of patients who cannot make it to hospitals and clinics will be grateful that there's a service at home for them. In the major laboratories in the country, in Accra at the moment, provide a service at home. And I know a lot of patients I've been to who say, yeah, when I think, I said, well, where will you do it? He said, oh, don't worry. So I just give them a call and they'll come and take the sample at home for me. Because the patient is bound and doesn't want to be lifted and taken through a wheelchair and all that into a car, or just to have a blood test. So yes, private clinics should not be worried. They'll probably get more business because patients will feel comfortable. Those who can afford it will feel comfortable that they are going to be seen and seen properly. If other health professionals from other disciplines need to be involved in their care, that will be provided. A comprehensive multidisciplinary approach to home care is what we are advocating.
Excellent. So, Barbara, I'll leave you to carry on from question 15 onwards, please. And that is question 15 from our viewers is that, given that some people already give medical home care in Ghana, how can the quality of such care be improved?
Okay. I've said most of that already, but again, quality has to do with auditing your service, auditing the things you do, good record keeping, good team work. So communication is key. Communication, I mean, there was a survey by the professional indemnity insurance companies. There are two big ones in the UK. One of them is the MDS, and the other one, whose name I've forgotten now, are the two big ones. Now, one of them did a survey and found out that 85% of complaints that are made against health personnel could be avoided if communication is good between health personnel, between health personnel and their patients, between the health personnel and the patient's relatives. So communication is key, and it goes hand in hand with record keeping. So that is important. Escalation, a clear escalation plan is important. If I'm a carer and I go in the morning and see that my client is not as well as she was or he was the day before, I should be able to know straight away what to do, and what we will advise is that you take vital signs, temperature, pulse, blood pressure, respiratory rate, enter the heart rate. Usually the blood pressure machines are able to tell you the blood pressure as well as the heart rate. And then if you have a clear escalation plan, then you relay your concerns to whoever is mandated to take decisions, or whoever is mandated for you to report to. There's at least some clinical measurements to add to the clinical story, the history, so that timely decisions can be made. So yes, there's a lot to do to improve. Simple bedside measures that don't involve sophisticated gadgets.
Yes, of course. I mean, to people, those of us who are probably more aware with the medical side of everyday life, or a bit more in tune with what's happening in the medical field, maybe it's a common thing or a theme to us, so we'll be able to look out for these sort of things. But to others that are not very aware, those that are in the rural areas, those that are and traveling, all sorts of situations, they might not be aware of these things here. So one of the questions which came from the panel, which is question 16, it says, what is palliative care?
I believe this was asked right at the beginning too,
yes.
Wasn't it?
Excellent.
Yes,
so we can ignore that. So we go to the next session of next question, sorry, so that we don't miss the time. Okay.
I think most of the questions have been asked because I think you told us what made you get into
yes.
care for the
palliative care. Yes.
You tackled that, and you also mentioned whether there were any care homes for the elderly in Ghana. You mentioned somewhere in Sakumono where your somebody you knew in England had sent their mother, was perfectly happy with it. And we also tackled if we had any names and addresses and phone numbers of palliative care clinics and homes in Ghana.
I mean, my internet search just revealed one that is in Medina, but I haven't investigated them to find out how good they are and all that. So I'm not ready to recommend them. However, there's a Ghana Palliative Care Association made up of health personnel who are interested in palliative care. I know that palliative care has been driven by a doctor whose name I've forgotten, but he's well involved in the family medicine program, the Graduate College of Physicians and Surgeons. And so there's a drive for palliative care. I'm hoping that I'll be able to join the association soon and learn from them, importantly, what they're doing, and share my experience, however little that I have, to be able to train. I think training is so important, because proper training gives you the confidence. Proper training helps you appreciate and realize when you've reached your limit. You need to call or you need a second opinion. I know that actually health personnel are not good at seeking a second opinion, and when patients have or relatives have sometimes gone to seek a second opinion, the treating doctor has been unhappy, the treating nurse has been unhappy. But I think that we need to appreciate that the body of knowledge there is so much that you cannot store it in one head. And so it's important to discuss things. This is why a multidisciplinary approach to palliative care and chronic conditions is ideal, because people bring up ideas and people take ownership and collective decisions are taken. And you're likely to get the decisions implemented because everybody feels were part of the decision-making process. So it helps. Teamwork is important. It's crucial.
Excellent.
To what extent are palliative care policies intertwined with Ghana's healthcare policies?
Admittedly, I haven't read the document, so I'm not the know. Hopefully, reading the document, I'll know what has been what is in there about palliative care and chronic. I suspect that there's something in there because I don't think the Association of Palliative Care Professionals has been met. But hopefully, when I lay hands on the document, I'll be able to look at it and provide some comments.
There was a question about whether there were any patient care homes for dementia and Alzheimer's sufferers, and your Mercy Care Home in Sakumono. Are there any others?
Not that I know of. There may be one or two other homes, but not that I know of. Mercy seems to be the only one that comes up when you search the internet as well. So I'm not too sure whether there are others somewhere, but have been approached in the last 10 years by so many people who have thought about it and want to set it up. I think the figures look a bit too expensive for the average person to pay for. I think that, or how I think we should go about it, is that we need to set up, intend setting up a care home where people are permanent residents. It is important to probably leave some beds for people who are recuperators. For instance, if someone goes to hospital to have surgery and the surgery is done, and 3 days later, the surgery, no complications, they are not ready to go home because they've got walking problems, might live in a flat upstairs, they might live in a story building, they cannot do the stairs, there's nobody at home to look at them. We have care homes that have few beds or to act as a halfway house where the patients can have access to medical care and importantly therapy, physiotherapy, occupational therapy, to have aids that can help them. They eventually get home, they regain their level of regular function, your pre-surgery function. So there's a role to play because hospital is not a place, acute hospitals are not a place to keep patients who problems, primary problems, admitting problems requiring admission have been solved just because they are not ready in terms of level of function to go back home. Those the bacteria and infections in hospitals are usually much worse than in other environments. So we must have is to take the patients, which as it is now in terms of funding, to be privately funded, so to be those who can afford it. If there is an initiative, government initiative comes in earlier, we need to consider the halfway house. In the UK, the halfway house is the community hospital. 15 years ago, community hospitals were admitting probably 90% of their patients from acute hospitals, people who had gone in with problems that were very ill, they had been sorted out and were not ready to go home, into community hospitals. That mandate changed. Now, in some community hospitals, over 50% of patients are admitted directly from home. So avoiding the acute hospital environment. Can you imagine? An elderly patient has got dementia, and then an ambulance to a busy A&E with people shouting, screaming, big machines going off and everything. It just worsens their condition. They become more confused, wondering, where am I? And if you move them to a hospital setting, where it can be done. Blood samples can be taken. Nurses can manage the care. Doctors are there to review. Observations are done. Observations like and all that I talked about, oxygen saturation. Decide whether these patients are fit enough to be looked after there, and escalation procedures in terms of the need to transfer them to these acute hospitals if they get worse are all in place. It's a better environment for them. I mean, I could talk about the Rapid Access Center that we set up in 2008 that was so successful at doing this. We engaged ambulance crew, we engaged nurses in the community and all that in the UK. And it worked. I mean, there were skeptics there. I realized about all these services is that the people running the service are not committed. They don't believe in it. They don't believe it can work. If they are directly risk averse, then the service will fail. Somebody starts vomiting, saying, "Hey, send him to A&E." And so, we need to train people to be confident. We need to choose the right people who are willing to deliver this innovative service.
Excellent. Thank you so much, Doc, for your time and also for this insightful session. Sorry, Barbara. Do you have any questions? Any further questions?
Yeah. So, very briefly, this is it's going to be extremely expensive because people will live longer, so they'll need more medical assistance, they'll need more care in the home and things like that. So it's important, like you said before, the youth are educated to take out insurance very, very early on.
Yes.
And that we have insurance companies that are good enough so that when you insurance for the long term and then you get ill, nobody knows how long you'll be unwell for, and nobody knows how long you're going to need these services for. So we should have insurance facilities that are able to take care of all these eventualities.
Yes.
So that when I pay my money when I'm young and I get to 70 years old and I need that care, I need to have the confidence that there will be the funds available to assist me at my point of need. So these are all things that need to be addressed and thought of very, very carefully.
Excellent.
You've given me an idea that we probably need our training programs to have somebody from the insurance industry come and give a talk on the importance of insurance and what policies are out there for us to
plug
into. Because we're talking about elderly. There are 45-year-old men and women who had a stroke and have become significantly incapacitated as a result of that. So the needs will largely be the same as a 65-year-old who is incapacitated from a stroke. So yes, if you start paying for health insurance at 25, unfortunately you fall ill at 50. There's that, which takes a lot of stress, financial stress, your immediate family, and make things smoother.
So, Doc, I mean, people as young as 30s and their 40s, when they do have a stroke, with the proper medical care, there's a good chance that they can, they can be revived back to normal.
Oh yes. I mean, the advent of stroke units has improved outcomes significantly.
Right.
So you have a stroke. The important thing is there's a fast, the fast acronym that has been looked at quite significantly. If you have a facial droop, if you have weakness in one arm, side, if your speech is slurred, then think about stroke and rush the patient to hospital. In advanced countries now, England and all that, if you have a stroke, you get a CT scan within 3 hours. The reason being that there are two types of stroke. You could have a stroke from bleeding, which is 15% of people who have strokes, bleeding to the brain, and so 85% strokes are due to clots, either small or big clots, use the blood supply to the brain, an area of the brain, and depending on which area of the brain hasn't got blood supply, you get symptoms or the signs. That affects your face, your limbs, one side, or your speech. Swallowing is also affected, and another thing. Importantly, the reason why I get a CT scan is that if it is not a bleed, then you can get clot-busting medication that we have used for years in treating heart attacks. Same clot-busting medication to hopefully deal with the clot, allow supply to the area that is affected, which has been proven to reduce significantly damage caused by the stroke, because it's a lack of blood supply. If you are able to get blood to the area that, to the tissues, the area in the brain, the tissues, the cells that have lost blood supply, you won. So strokes are treatable. Strokes, you can get better with a stroke. Importantly, after that acute phase where you are monitored for anything up to 7 days after a stroke,
okay, Marin, go back.
Good care and all that, prevention of chest infections and all that, you come to the rehabilitation phase, where most of the work there is done by the therapist, physiotherapy, occupational therapy, pushing you hard to regain your level of function with all sorts of regimes, exercise regimes, with occupational therapists helping you recollection and performing basic tests to be able to determine the deficiency and how to correct it. Speech therapists coming in to help regain your speech. These are proven work. Now with rehab, most rehab stroke units are also moving on early discharge of patients from stroke units and continuing the therapy in the community, the home. So most conditions that were traditionally treated throughout in hospitals are now being moved towards home. And it's not just driven by trying to save money. It's driven by the fact that in your own home, you feel more comfortable, you're more likely to cooperate with therapy, you feel you're back to your base, you probably will be less depressed than lying in some strange place in the hospital where you see your loved ones only 2 hours a day due to visiting time restrictions and other things. So the drive these days to towards an early discharge has been shown to be better for patients. It ties in with the home care initiative.
Excellent. So, Barbara, have you got any further questions?
No, I don't think that I do. I mean, we've established that we need insurance. We need to have it regulated.
That's right.
And we need proper training.
Yes. Yeah. I mean, I have thought that we should. I mean, it's easy. You can sit down and write a training manual, but I think that when one person or a small group of people write training manuals and all that, there's no ownership. It's better to put carers in the room, or representative of carers in the room, representative of medical people in the room, nurses there, therapists, and everybody, and they come together and write a training manual that is most likely to be useful be used, accepted, than just a pen manual off some shelf somewhere and using it, pushing people to learn, use it to learn. So yes, we have to design our own training manuals and training courses and all that, which will be easier once we have evidence, which we'll gather as we go along.
So Doc, is your healthcare center live and working now? Is it fully operational now?
It's almost operational. Still have some technical problems to deal with. I have will get away with using funds and all that. Having spent some time during the day here, it's so hot here that we need air conditioning.
Mm-hmm.
So, will that cost be transferred to the patient remains to be seen. Maybe some philanthropists will come to my aid.
Yes, we will hopefully
work to keep the fees affordable.
Yeah.
I am aiming to get it up and running by the end of the month.
Excellent. And how many rooms and beds and what's your facility?
So again, begin with the property is not big enough to run admissions, and I think it's always good to start with an observation ward. So we've got 4 beds, an observation ward, then the consulting rooms. There are plans to get a dentist to take part of it so that we work together. And the 2 consulting rooms. My vision is to get different specialists with different skills come and do consultations here when they want to bring their own patients. I can prepare patients to them. Importantly, it's the quality that we seek to achieve. A lot of colleagues in Ghana and outside Ghana who probably would be happy to consult in an environment that is conducive for them with the least hassle. They come, they see their patients, they don't get involved in administration and all that, HR issues and all that, the day-to-day running. And I think that is what I'm hoping will come out of this project. So keep our fingers crossed. We will get there. I have no doubt.
Excellent. So once again, we'll say a big thank you to Dr. Fobi Amankwa. Thank you for such an insightful evening. We have become very aware of our elderly and how we can care for our elderly. There's hope, there's help, and hopefully there are people and hospitals and clinics who are currently working on establishing places that we can take our elderly parents to. Would you like to round up the session by telling us something, advising us, anything that will help us in case we're going through this?
I think I'd like to thank you for giving the opportunity to talk about something I'm very passionate about. I think that stay healthy. It is said that if you do any form of physical activity, 30 minutes, 3 days a week, more than enough. I urge you when you go to the shopping malls, park your cars furthest away the entrance so that you can do some exercise. Exercise when you can helps in so many ways, and eat healthily. Don't overindulge in anything. I think that's the message I have. And we are determined to deliver a service taking into account patient needs and all that. And so do not hesitate to contact us if you have any problems. If we don't know who can fix your problem, if we cannot fix your problem, know who can fix it. So we don't worry at all about getting second opinions and all that. Let's stay with us and have a good evening.
Thank you very much. So, Doc, if any of the members, the viewers, if anybody wants to be in touch with you, how can we get hold of you?
Okay. My WhatsApp number is 0044 7930 942 795. My mobile number in Ghana is 00233 274 585 888. Emails can be sent to Fobi, all lowercase, _ AMANKWA without an H. So FOBI _ AMANKWA at hotmail.com. Sure to get a response from me. We are aiming to get a website up where there will be Adusa-Amankwa Health Center, where there will be opportunities for questions and answer sessions. So we're dedicated to this, and we will deliver.
Excellent. Thank you very much, Doc, once again.
It's been a pleasure.
Yeah.
So happy with you.
We are happy you're with us on Business Links Africa. To our viewers, thank you for joining us. Thank you for being there and listening to us. Unfortunately, the lines weren't so clear because Doctor has just moved his new facilities, and we basically tried to get him in as quickly as possible. And so we're having system connectivity issues, and we'll try and get him back once again. Doc, once you go live with your healthcare center, so that you can tell us a bit more about how you're getting on, and also advise us further, because now we want to know a little bit more about you. We'll also try and get our members to speak to you who are actuaries, so that we can discuss the insurance issues with insurance and how best we can get our members and our viewers and our people insured, because these are issues that are quite life-threatening to all of us, including our parents, our brothers and sisters, and people that get ill all of a sudden. So thank you very much, Doctor. If any of the viewers has any further questions, please feel free. You can always use that link, and you can connect with any member of the team, the administration team.
Really?
Thank you so much, Doctor. Thank you, Barbara, for being our moderator for this evening. Thank you, Alf. Thank you for all our backstop coordinators. There's been so much involved with trying to get us all together so that we'll be able to have a good session today. And thank you to all our viewers once again. Hopefully we'll see you in the next session in the next couple of weeks. Thank you and goodbye and good evening. Bye.
Good evening.
Barbara, did you have anything to add to it? Hello, Barbara. I think that's Barbara. Hi, Barbara.
Oh, sorry, I got cut off there. No, I don't.
Yeah, I can hear you.
Can you hear me?
Did you have anything to tell us to wrap us up?
Doctor, thank you very much, Fobi.
You're welcome.
Thank you. No, I don't.
You're
thank
welcome,
you very
Barbara.
much, Fobi.
Okay.
And have a nice week.
Bye, everybody.
Bye.
Bye.